Hi guys, it's raining actually. So let's go to next question. You are assigned to a patient who is having a CVC, a central venous catheter. You entered in the patient room and you see this patient lying. The CVC is dislodged and the patient is lying. It's lying. The CVC is lying on patient bed. Okay. The client appears cyanotic and is tachypnea and diaphoretic. Which of the following action by you will do first? You have to select all that apply. It's a very serious condition. This patient is going to die if you don't act promptly. Okay, let's see the administer. The first option is administer oxygen via non-rebreather mask. Second option is apply an occlusive dressing over the incision site. Third is assist the client to high Fowler's position. Fourth option is monitor vital signs and respiratory effort. Fifth is notify the healthcare provider. So let's go and see what is left lateral Trendelenburg position you are giving to this patient. If you find a patient is with the CVC dislodged, cyanotic, and other symptoms is showing that there is catheter is the CVC is out. Okay, so what the first thing what you have to do is air embolism to prevent it migrating the emboli, okay, to the pulmonary system. So air embolism is a rare but a life-threatening situation. Complication of central venous catheter, placement in which air enters the bloodstream. That's what happens. Then it is blocked and the air exchange not takes place and the patient go into pulmonary embolism and die. Okay, this air displaces blood in the pulmonary vessels, which prevents oxygenation of the blood by the lungs. So when this blocks the air exchange, oxygenation is not taking place. Then air embolism may occur after CVC removal, as well as air can enter the bloodstream via the open large bore insertion site. So that's what happens when this, because this is dislodged, so there is a big open area there, so the air can enter inside. Okay, that's what dangerous situation you are facing at this point. Now client with air embolism can rapidly develop respiratory distress, leading to cardiopulmonary collapse. Nurses caring for clients with the symptoms of air embolism, for example, patient will have hypoxemia, means lack of oxygen in the bloodstream, then dyspnea, sense of impending doom after CVC removal or dislodgement, should perform these actions. The action what you have to apply immediately, you apply occlusive dressing to the insertion site to prevent the entry of additional air into the bloodstream. So you are preventing it. So further air entry is immediately prevented by applying a occlusive dressing. Then administer 100% oxygen via non-rebreathable mask, not rebreathable, non-rebreathable, because you have to give as much as oxygen you could improve oxygenation. Okay, that's the purpose. Then position the client in left lateral Trendelenburg position to promote venous air pooling in the heart apex rather than the lung capillary bed. Lung, if it go to the lung capillary bed, there is no exchange take place. The gas exchange is not taking place. When it stays there in the heart apex, so it is trapped there. So it is less serious. You have some time. You are borrowing some time to resolve this. Okay. Continuously monitor vital signs, client respiratory effort to identify changes in client status. Then notify the healthcare provider immediately. Okay, these are the steps you have to do. So applying occlusive dressing, administering oxygen, positioning the left Trendelenburg position, and notify continuous vital signs checking, then notify care provider. Okay, then if you do instead of a left lateral, if you put in a high Fowler's position, what will happen? Will worsen the respiratory distress caused by air embolism by promoting displacement of the venous air embolism into the pulmonary circulation. That's what happens. Okay, you are promoting it. You are telling the air emboli to move to the pulmonary system and kill the patient. Okay, so never do that. Next, let's see another question here. So Okay, you are teaching some patients. Some educations are given to this patient. So this patient, the patient number 1 is a client with peripheral artery disease, PAD, who insists on dangling leg over the side of the bed when sleeping. Then the second client is with a Raynaud's phenomenon, who routinely soaks hand in warm water before going out. Then the third is client with venous leg ulcer who refuses to wear elastic compression stockings during the day. The fourth is post-surgical client who points and flexes feet when lying in bed. So we have 4 patients. All of them were given education, but you have to see you need to follow up with them. So means lack of knowledge. So when you educate the patient with lack of knowledge, this can what you expect the patient to do, if they don't do that, their situation may worse. So let's see which patient need a correction or follow up. The nurse needs to provide education to the client with venous leg ulcer who refuses to wear compression stockings. So that is the patient you have to follow up. Compression is essential for the treatment of chronic venous insufficiency, venous ulcer healing, and prevention of ulcer recurrence. The client will need individual evaluation to determine what level of compression is needed. Okay, so you have to measure and see. The client will need individual evaluation to determine what level of care is needed. Assessment of the angle brachial index, ABI, should be performed as well. An ABI of less than 0.9 suggests concurrent PAD, peripheral artery disease, and the need for lower level of compression therapy. There are several options that nurse can explore with the client to decide which compression device will work best in the situation. Custom fitted elastic compression stockings, elastic tubular support bandages, Velcro wrap, paste bandage with elastic wrap, or multi-layer bandage system. So the option 1, the patient who had a peripheral artery disease, PAD. So dangling a leg, first one, dangling a leg over the side of the bed is a common practice among PAD clients to relieve pain, because these people will have intermittent claudication to the pain they will have. So they dangle the leg. This is no needed. So let them do that, because when they dangle their leg, due to gravity, the blood flow increases towards the lower extremity. So that's a good thing what they are doing. The second patient is immersing hands in warm water before going out. That's a good thing for the Raynaud's disease, which is vasospastic situation. So that relieves. Okay, that's a conservative management there. We have to let that patient do that too. That's also a good thing. So she knows what she has to do. So no need of follow-up. Then the fourth option here, the practice should be encouraged by the nurse. It can help prevent venous thromboembolism following surgery. So the post-surgical client who points and flexes feet when lying in the bed, that you have to promote, because it can help forming venous thromboembolism following the surgery. So this patient has to be followed up, who is not wearing the elastic compression stockings. Okay, the patient with the venous leg ulcer, that one has to be followed up. Now, next question. So the nurse reviews laboratory data for a client admitted to the emergency department with the chest pain. Okay, you have a patient with the chest pain. Which serum value require most immediate action by the nurse? So you have to think this patient is having chest pain. Keep that in mind. Okay. So the glucose 200 mg per deciliter. Then the second is hematocrit 38%. The third is potassium 3.4 milliequivalent per liter, and troponin 0.7 nanogram per milliliter. So which one you have to immediately report? So serum cardiac markers are protein released into the bloodstream from necrotic heart tissue. after a myocardial infarction, after heart attack, what happens is there are proteins present in the muscle, they are released in the bloodstream. It's a very serious condition. So how you measure this is troponin is a highly specific cardiac marker for the detection of MI. Okay, so this is positive. If it comes positive, the read, if troponin high, that is a cardiac marker. It is telling you that this patient had a heart attack. It has greater sensitivity and specificity for myocardial injury than creatinine kinase. Than CK, creatinine kinase, troponin has more sensitivity and specificity for MI. Okay, so serum level of troponin increases 4 to 6 hours after the onset of MI, peaks at 10 to 24 hours. So it increases. If a patient comes to you, so they suspect the patient is having a chest pain, you are doing a troponin, maybe that comes normal, but in 4 hours you are repeating it again to see that whether this patient had, because 4 to 6 hours it increases and it peaks also. It peaks in 10 to 24 hours. So you are doing a series of tests in this patient, and it returned to the baseline in 10 to 14 days. So after that, if you do after 2 weeks, you may not detect that this patient, whether the patient had a cardiac arrest or not, myocardial infarction or not. Okay, so the peaks between 4 to 6 hours after that onset, troponin increases in 4 to 6 hours, then it peaks between 10 to 24 hours, and it comes to the baseline between 10 to 14 days. So you have to chest pain patient, and first focus you have to here give to the troponin level. Okay, troponin value of 0.7 nanogram per milliliter, 0.7 mcg, indicate cardiac muscle damage and should be priority and immediate focus of the nurse. Normal value troponin 1. Then troponin I is less than 0.5 and troponin T is less than 0.1 nanogram per milliliter. Option 1, the glucose is elevated. Normal random glucose is 7 to 110 mg per deciliter or 3.9 to 6.1, but is not the priority at this situation. Okay, this can be treated later or to be assessed later. Okay, the nurse will need to assess the client with a history of diabetes, and you have to see later, you dig in the history of the patient, whether time the last meal, what time was the last meal, and the patient diabetes, all those things you have to ask. Option number 2, normal hematocrites for a male is 39 to 50 and for female it is 35 to 47. So the hematocrites value is not the priority at this point. Then option number 3 was the potassium is slightly below normal. 3.5 to 5 is normal. Here it was 3.4. So this should be the nurse's second priority. A low potassium level can precipitate dysrhythmias. Okay. So the first is troponin level. Second is the potassium. Okay. Then all the glucose and hematocrites, everything is required. Then so I think that is enough here. I'll come with the next video soon. Thanks for watching.